We'll move on to some of the updates from the subcommittees. Manoj Kudivali, who's the chair of the SCTS Adult Cardiac Surgery Subcommittee, is unfortunately unable to make it today, so he's kindly put the presentation together, and I'll be just presenting it on his behalf, but I'm happy to address some questions at the end. So the first one is about the NHS England TAVI AVR position statement that was put out early in the year. I addressed it in the presentation earlier, but just to reiterate, it's something that we are challenging NHS England about the validity of it. We've asked them to revoke the statement, and we don't feel it's appropriate to be putting patients through treatment choices that would not be normally their first choice, just purely on waiting times. It is incumbent on us all to do what we can to change waiting times, and the slide that I showed you earlier are some of the initiatives that we're doing moving forward. But if there is equipoise for a patient, they should go through a robust MDT, but otherwise the guidelines are clear on which patient should have surgical AVR, and it's, as I said, incumbent on all of us to be the advocate for the patient in these situations and in these MDTs where you may have some people aggressively pursuing a different option. We've sent letters to the NHS England. We've had meetings with them, and as I said, we are actively pursuing a change in that moving forward. In addition, Mahmoud Labani and Giovanni Mariscalo from Leicester are putting together some evidence, some information, details about the prospect of randomized studies to allow all of you as individuals, when you attend these MDTs, to have more evidence to back up what is in the guidelines, what is appropriate for the patients that you're discussing to ensure that they get the right outcome for patients. And as I said, we've sent out the survey to all unit reps. Thank you to all of you that have replied, but not all units have replied, and we'd strongly encourage those who haven't to give us that information to allow us to put our case to NHS England. It's a really powerful case that I think Manoj has put some of the information on the slide. So it's a really powerful case if we can actually say to them, in a lot of units, the TAVI waiting times are longer for surgical AVR. So I think Manoj has said there's 8 units have responded so far. There's a reminder that went out, I think, this week, and it'll be really useful information to put to NHS England. So the results of some of that we've had in so far about whether all your elective aortic stenosis, severe aortic stenosis patients are coded as P2, and it's about a 60-40% split between the units, putting all of them as P2. In terms of the waiting times, you can see the split, and in many of the units, if you look at the second column, the TAVI waiting time is longer than the surgical AVR waiting time. And if we can have this information for all units, it will give us a powerful case to put forward to NHS England. The last 2 columns talk about the numbers that are done in your different units. We've seen from the national NICOR data that there is a great swing from TAVI to AVR in terms of percentages. This happened significantly during during COVID, and the TAVI numbers have reduced a little bit since, but are still higher than the surgical AVR numbers on average. But it'll be really useful to have those numbers from your own individual units. And these again talk about the different numbers that are done and how much units have returned to their pre-COVID levels of business as usual. So again, it'll give us information to see about the elective recovery in that as well. The second big initiative that Manoj and the team are taking forward, and this is work we're doing with NHS England, is about changing the quality of care that we deliver for patients undergoing mitral valve surgery. Enoch talked about a little bit about the trial that is being run through NIHR, but it's about how we results that came from the mini mitral trial, about how we as a community increase the repair rates that we can give. From the trial, it showed that up to 95% of some units are delivering up to 95% of repair for degenerative mitral valve surgery. But if you look at the national data, that isn't happening in all units. And I think it's incumbent on us as the society, but also as individual units, to drive up the quality of care that we give to patients. We know mitral valve repair for patients with degenerative mitral valve disease has better long-term, short-term and long-term outcomes in terms of their prognosis. So what we can do to try and change those rates, we're collecting, again, we're going to soon be putting out a survey to collect the data for what you think the different changes are needed in your own units, whether you run MDTs, whether you have specialist mitral valve surgeons, how mitral valve surgery is divided amongst your units. And also we're working with BISMIC's team about putting a best practice guidance document about how to improve some of these repair rates in individual units. As I said, for a while, a lot of the data that's submitted to NICOR doesn't distinguish from degenerative from non-degenerative patient, but we're getting that data. And that's, again, the importance of why having our own adult cardiac surgery database will allow us to extract this information in this context for mitral valve patients, but actually for all surgery that we conduct to improve the outcomes that we deliver. And then Manoj has asked us to plug a couple of events that we've got coming up, and you'll have seen advertised in the weekly newsletter is the ACTAC SCTS Joint Study Day on the 6th of November. There's a cardiac and thoracic stream running separately. So Karen and the team have set up the thoracic stream, and Manoj and the team have set up the cardiac stream. Encourage you all to attend. It's a joint study day with the Association of Cardiothoracic Anaesthetists and Critical Care Specialists, and about how we can improve our joint working together. And it's got lots of clinical and professional development aspects to the day. All the details are on the website and on the newsletters. And then also there's a joint meeting with the British Heart Valve Society, their annual meeting with contributions from the SCTS and BISMICs. And again, all the details on the website, and encourage you to attend. Again, it's about us working with other organisations to improve the clinical outcomes that we deliver for patients. It's a brief overview of what's going on in adult cardiac surgery on top of what I presented earlier. Welcome any questions any of you have related to adult cardiac surgery. Questions probably online. Steve. Just to wait for the online people, won't be able to hear you, so apologies.
Thanks very much. Steve Billing from Wolverhampton. Just very briefly, this TAVI versus surgical AVR data is critical. TAVI explant in the US, to my understanding, is the fastest growing adult cardiac procedure. There's a reported 15% mortality. Of course, it will depend on the patients involved. So it's a really key question. And if you're not getting answers from individual units, I don't know anything about our unit as to whether we've replied. Can I suggest that you send an email to everybody?
We've got a staged approach. We're trying to do it through the official infrastructure. The final part of it is telephone calls. So yeah, we will get that data, but I echo your thoughts, and the negotiations we have with NHS England, it is really powerful. Waiting times, outcomes, the manuscript we sent in rebuttal to the NHS England position statement had one of those manuscripts about 10-12% mortality about TAVI explants. Putting them in young patients where it is not clinically indicated is the wrong thing to do, and any help we can get from the units about pushing that forward would be really appreciated. So thank you.
But I think in each unit, recruit as many SCTS members as possible to push to provide the data.
I echo that. Will. Yeah, I got it.
Hi, Afsal Zaidi, Swansea Cardiac Surgery. I've been involved in the single point of access care for aortic stenosis, which we have up and running in Swansea. And I can tell you that it's impossible in Morriston Hospital, Swansea, for a patient to inappropriately get a TAVI. I mean, every patient is jointly triaged with a cardiologist and lead surgeon together to make sure they see the appropriate person initially, and for the people in the intermediate range, they're seen in a joint clinic with a surgeon and a cardiologist. Because one of the problems with it, if you only rely on an MDT without a surgeon, without the patient, you're actually missing. We can all look at an echo, and someone can tell you, yes, it's a frail 78-year-old. But if you're there in the clinic and they tell you that they go cycling, that patient in our unit gets a surgical AVR. We get 81-year-olds with surgical AVR because we see them. So I would recommend that in every unit in the UK, you push single point of access. There will be a paper coming out about this soon from about 3 units that ourselves, I think Guy's and King's are doing it, and maybe Middlesbrough, but one other unit. So I would recommend that you sit with one of your lead cardiologists. We're lucky in Swansea, we have a very straightforward, frank and fair lead TAVI cardiologist, and that's why we've been able to push it. But you must join forces with them.
Joint forces argument is crucial, and we were lucky last year put out the Joint Society guidance on multidisciplinary working specific to coronary artery bypass graft, coronary artery disease, aortic valve disease and mitral valve disease. There is a clear infrastructure, as you've alluded to, and I'd encourage all of you to look at that document and use it, because as I said, we are the advocates for the patients to make sure they get the right long-term treatment for their clinical condition.